Hi class, this is Professor Stanley, POLI 4012, and today we're going to be discussing Chapter 7, the healthcare system. Now, there is a lot to discuss in this chapter, and there are obviously a lot of opinions about this chapter, especially given the recent emphasis on reform in the healthcare system by the executive branch of the federal government. However, we will be sticking to mostly the academic script, okay? Which means I'm going to be telling you what you need to know in your field and how to apply it, all right? Um, Discussions and things of that nature about your thoughts and opinions toward the healthcare system are best left to the discussion board. And you all know that by now, my goal as your mentor and your leader in this classroom is to give you the balanced approach to the material. All right. Uh, okay, so I fly airplanes. I've got a couple hundred hours on a Cessna, right? Now, when I come in on a final approach, the way I do it, the mechanics of it are the same. You slow the speed, you take the power out of the aircraft begins to fall, and you start to glide. The same thing is my approach to this material. Every topic we discuss, our approach in which we discuss it is the same, and my approach is one that is academic in nature. I understand this is a highly charged topic, and for those of you that may get to know me outside of the class, maybe in the future, I will gladly share my personal opinions with you on the regulatory system in terms of healthcare or any other type of question that you may have about the healthcare system. But as a student, I'm going to tend to stick to the script and tell you what we do know, and that applies to your role in the field in the future, right? Okay, so now that I've got that precursor out of the way, I'd like to jump right in here. And this will be a brief lecture. I don't plan on making it a long, extensive, drawn out affair. However, I will go over the things that we need to know and maybe spend a little bit more time on some things versus other things. All right? So, for those of you that have had a chance to look at the material, you'll know that there are three basic models to care in the United States. Three basic models to healthcare. All right? Number one, the medical model. This is the oldest model, obviously. Okay, um, its emphasis is on institutional care. So, any type of care that you would receive in a doctor's office by a physician or in any type of hospital or other institutional environment. Now, the emphasis in medicine is on outcomes. In other words, how do we diagnose the problem and cure the problem? Um, you know, it really depends on which part of the hospital you're in, but if it's the ER, for example, uh, we want to figure out how to cure or treat the patient as quickly as possible. Now, when they get to the upper floors, the treatment process is a little bit more drawn out, and since it's no longer considered a technical emergency. Uh, and as an EMT, a volunteer EMT, I do have a lot of experience in the emergency room with these types of situations, and all the nurses and doctors that I've talked to always emphasize, you know, the triage process and getting the patients in and figuring out who needs more priority versus the other patients. But that's another discussion. However, that is part of the medical model that I want you to be familiar with. Okay, so you'll see at the bottom little focus on prevention or community-based care. And as you've learned throughout the course, this model has really changed because a lot of the care is actually focused now on home and community-based, especially for elders. And that's our topic here in this class, elder care. I actually saw a mobile treatment van on the interstate the other day that goes into the communities and into the homes. And I think there was an RN or some other staff on there, perhaps a physician. Believe it or not, there is a growing demand for these types of things. And we learned about that due to what we came to know as urban sprawl. After World War II, people went into the neighborhoods, and like the video that we saw a couple weeks ago, where the way society is designed, our capacities in the hospitals and in inner cities are not able to cater to these people. All right, so you can see that the medical model of care is one that it is the oldest model of care in the healthcare system that focuses solely on diagnosis and cure. The next model of care is the social model. Okay, this World Health Organization actually includes in its definition that health is more than the absence of disease, not just wellness or the absence of disease, but also the ability to function in society, uh, and not just fitting in and going to the right cafeteria table and sitting with your favorite lunch crew. Um, that's another one of those built-in jokes that I have for you. But also, we want to focus on the functional capacity. All right. Uh, Things that you want to note from the HR perspective: studies have indicated the last couple of decades that a productive employee is one that is able to communicate effectively, right? So, obviously, a person that is not very social will not be very functional or capable in a very stressful workplace, especially if it's in healthcare. All right. However, this model does give us a little bit more insight into care that takes place into the community. One of the big barriers that you find in the treatment of elders, you'll learn in the field, is that a lot of it has to do with depression and the lack of social interaction with these people. All right. Um, and studies have linked overall health related quality of life directly to the levels of depression that elders experience. Okay, so you want to be aware of that. The social model is becoming something that is more and more emphasized in our field. So just keep that in mind as you go through and you learn about the three models of healthcare. The next model of healthcare is the health promotion model. This is another model that has become more relatively emphasized in the healthcare system today in the United States. Scientists and medical professionals have accepted the findings of studies that indicate that disease prevention habits and also activities that an individual does actually reduces the chances of an individual having a disability or a limitation in their activities of daily living. Okay, so examples of this are, at the very basic level, diet and exercise. So you see a lot more things out there like commercials and community organizations that are actually focusing on promoting a lifestyle that is relatively healthy. Okay. The model also does explain the fact that you can regain lost abilities. Now, the extent to which the abilities that you may regain would obviously be correlated to the level of injury sustained or level of loss of capacity within an individual. Okay, so I don't want to spend a whole lot of time on this model because we have other things to cover in this lecture, but I do want you to make you aware of the health promotion model and sort of the reasons why it was created. Okay, hospital discharge rates here. Now, I know this information is a little bit aged, if you will. And that was just another one of those built-in jokes that I have for you. But if you take a look at figure 7.1, hospital discharge rates since 2006, you'll notice that they have actually gone up. The length of stay has gone up in terms of the days they are treated within a hospital setting. Okay, and there are a number of different reasons behind that. And we'll talk about that for a little bit. But basically, if you look at the numbers, they will show you that the discharge rate is positively correlated with the average length of stay. Now, in the case of our course, we discuss the older population, also known as older people, also known as geriatrics in healthcare. Now, after World War II and the industrialization of American society picked up, we had roughly 50% of people that had health insurance until about the mid-60s. Then we had social insurance programs. Those are known as Medicare and Medicaid that help the older people, and they're run by the government. So obviously private interest groups such as the American Medical Association, that's what the acronym is for AMA, were very much against, and for the most part are very much against any type of socialized medicine. It's what it's called. And we heard all these arguments in 2010, for those of you that are old enough to remember that. Basically, everyone was upset because the Affordable Care Act was a very large-scale version of Medicare and Medicaid. Okay? So the doctors couldn't get as much money as they normally would get. That's pretty much the bottom line there. Medicare has a couple different parts to it. Part A is the largest portion. It includes your hospital insurance. That's the part you actually see coming out of your paycheck every however often it is you get paid. Part B is the supplemental part of medical insurance. You have to be eligible to receive those benefits as well. Part D is the newer part, which is a prescription drug discount card. Okay, so it does try to mitigate some of the costs for those people that are older, and typically older people have a larger number of prescription medication, and that's in the general population, not including any kind of sickness or diseased population. How much is spent and where in the U.S. healthcare system? Let's look at it for a second. Number one, and I won't go over all of these. I'll go over the major ones. Number one is hospital care, roughly a third. Okay. Physician and clinical services, 21%. And coming in next, we have prescription drugs at 10%. Now, you have your other professional services, dental care, nursing home, home health, those types of things. However, they do not take up a large portion of the spending. still noteworthy nonetheless. Oops. Now you can see at the bottom, total spent is 2.3 trillion. If you want to scale that, that is roughly a 10%, a little over 10% actually, of the GDP in the United States of America. And that number has increased. I'm giving you a rough estimate off the top of my head. However, that information is available publicly anywhere you look. Search engine, Google, or for those of you that even like to go to the library, if that's still a thing, all that information is available. If you're one of those people that like to focus on cost, number of Medicare beneficiaries, and also I want to include Medicaid beneficiaries as well, because that's actually the population that my research focuses on. The numbers have exploded over the last couple decades and will continue to essentially double if you compare 2010 to 2050. All right, and the 2030 problem is what I've told you all about. The year that the number of Americans will be at the number of Americans that are 65 and older will be at a very high rate, 20% of the population. So what we're doing is trying to figure out outcomes and clinical guidelines to help essentially maybe sort of lower the cost or improve the quality of life and improve outcomes in that population, because we've already discovered that that population will be there regardless, okay, of what happens. Spending total Medicare expenditures in the last 40 years, you can see that it's a large increase. All right, and I know I'm saying that in layman's terms. However, it is what it is. It's very simple to understand that the costs are rising and are frankly out of control, because the adult population, the aging population, is something that can't be stopped. That's why I like to focus on the impact of population groups themselves, okay? Because the illness and disease is often variable. However, age applies across all races, all groups of people fall into an age category. So you can see there the Medicare cost as a share of GDP. I said a little bit earlier, roughly off the top of my head. However, the book tells you it's a little bit lower. The numbers, if you factor in Medicare and Medicaid, okay, they're even higher. So roughly 12 to 14% actually is a more valid estimate. Okay, for those of you that like to look into the details of what the plan pays, Medicare Part A pays for your hospitalization. We talked about that earlier. Skilled nursing facilities, home health care, and hospice care, Part A, and that actually tells you what's covered, how long it's covered, and the average cost that you would pay. And also Part B is explained, which is the medical expenses side of things, and your home health care as well. Keep in mind that you have to meet certain eligibility, you or your clients would have to meet certain eligibility requirements to receive benefits from the program, okay? Medicaid is the other program that I was telling you about. Began in 1965. It has advanced rapidly, especially with the changes that were made in the Affordable Care Act. The idea that Medicaid and Medicare were passed to solve these problems is a valid point, is a valid idea. However, you'll note that the program eligibility varies, okay? If it's even available, it varies by each state. That means the state and the federal government have to work together to create these programs. Okay, so if you are advocating for these types of programs, then you will see a lot of resistance in private interest groups and things that we've talked about and you learned about in POLI 2051. Basically, reasons why they would want to limit the eligibility is because they don't get as much of a market share, total dollar expression when it comes to seeing privates cliently. Okay, so that sort of makes sense if you look at it from the perspective of a PCP, perhaps. If they are taking payments, they have to meet quotas and see a certain amount of patients. So you see a lot of practices that no longer take social insurance for a number of different reasons, primarily because it does sort of hamper or limit the bottom line. Anyways, the state does set the income and asset limits, and as you know, this is very important that you remember this, okay? It varies state by state. The federal government sets a general guideline. However, each state is able to adapt those guidelines that depend, the majority of which depend on the actual population of that state. Okay? So think about it like the government sets an average, and each state is more definitive in those averages and actually how they're going to spend the money. A state legislature does not have to vote for these for the expansion of these programs. They can have the very minimum that is required. But for example, home and community-based care, a lot of states don't even provide programs for vulnerable populations. Okay, so you want to keep that in mind as well. Figure 7.6 breaks down where social insurance payments go. Now that number that you see on the left, long-term care, has actually risen to more roughly 40-45% today. Acute care costs, on average are higher no matter what age bracket or what population you're looking at. The acute cost of care are generally higher, especially if it involves hospital emergency rooms or things of that nature. Okay. Funding for long-term care, Medicare and Medicaid take up the majority of the expenses. And again, these numbers are outdated. The percentages are more rough. I would say roughly around 55%. I think those are the last numbers that I looked at compared to private insurance. That number has stayed about the same. Actually, it's decreased a little bit, more along 30%. And in nursing home care, you can see that Medicaid pays for the majority of that. So those of you that are thinking about getting into SNFs or skilled nursing facilities or any type of administration that may be dealing with Medicare, you really need to emphasize and familiarize yourself with the program and how it works in your state, the regulations and the guidelines. Because it can be confusing. Remember that it varies state by state. Okay? Now, other healthcare plans, you can see that there has been a growth in the long-term care insurance industry. However, that growth has not even been comparable with the growth that you see in the Medicare and Medicaid programs. And there are a number of reasons for that, some of which we've already talked about, namely economic conditions. Um, and what we mean by that is that people are working longer and they don't have enough money to get their own plan in a private market. Okay? So it all looks good on paper, but the bottom line here is you have a population that is growing leaps and bounds, and there isn't an infrastructure in place by the government to take care of them because most of them need government assisted social insurance because they can't afford their own plans. I've sold healthcare insurance and I know that it comes to cost. That is the number one concern on the consumer's mind. It's not access. Anyone can access care in the United States, especially if it's an emergency. Okay, um, that's just how it is. But the problem here is that everyone thinks they've got a solution to universal health care. And the fact of the matter is, it is almost, given the design of the United States. Okay, let me give you a precursor here. Everybody wants to know the solution or the key. Well, the fact of the matter is that there is no solution or no key that's going to be a one size fits all type thing. Every state is designed differently, and the Medicare and Medicaid programs are designed differently. And to think that anyone is going to implement any type of standardized system across the U.S. of A., it's far-fetched. That's just the bottom line. Okay, now we do have these guidelines in theory. Yes, the CMS, the Centers for Medicare and Medicaid, do have these guidelines in theory, but the bottom line is it's very difficult to implement these guidelines because of private interest. Okay, companies have their own way of doing things. All they have to do is meet what's known as the minimum data set requirements for each state. Okay, so I don't want to overwhelm everyone with too much information there, but just keep those things in mind. All right. Okay. Total of healthcare expenditures as a percentage of gross domestic product. It's interesting here to see that the U.S. on average spends per capita more than any other country. Some of you probably already know this fact if you've taken other courses, health-related courses. Okay. It's not a big surprise. It's not a big secret. So the cost of care is higher for a number of different reasons that we do not have time to get into. I simply want you to know that the United States has some of the highest healthcare costs in the world. Now, we can bring up the economies of scale argument. We can say that it's because of inflation, it's because the dollar is worth more. However you want to cut the argument. There are a ton of different ways to do it. But my job is to show you things, and I will show you here that the U.S. is spending more per capita than anyone else. Okay, so the cost of care is something you want to familiarize yourself with, especially those of you that will be in charge of your own facility. Okay, so again, the textbook doesn't always show you what to do. The textbook gives you a good idea. The textbook tells you that there are rules and regulations to go by. A successful manager or a successful business owner finds creative ways. Now, let me put a context for you here. Creative legal ways to do things and to cut costs. Because if you see, in the book will tell you, after World War II, the United States is pretty much number one in healthcare spending as a developed nation per capita, and we just talked about that, with the cost expected to rise. Uh, and again, a number of different reasons there based on the economic factors that we talked about a second ago. And the fact here is, I want you to get the bottom point there. The bullet says rising healthcare costs explain most government spending on older people. Okay, so the older crowd makes up a large population of spending. Let's talk about out-of-pocket healthcare costs, also known as OOP, what we like to use in the industry, out-of-pocket. You can see they've basically doubled since 1970, and that number is even higher. New data would suggest probably roughly more around 28% at this time. Also, the insurance companies contributed to this in a lot of different ways because there were certain conditions that they would not insure, or they would put a rider on. And what a rider is it's basically excludes a condition that a person has, a pre-existing condition. To make a long story short, though, Obamacare tried to effectively solve this by forcing the insurance companies to give everyone health care insurance. That was the theory of the whole thing. But the reality was that the only people that were signing up were people that really needed it. They really needed major medical care. Okay. Typically, the premise of having insurance is to protect you against something that's going to happen. So you can see the irony there and why the costs have risen with healthcare insurance. Okay, and we talked about this a little bit. People are continually paying more money despite increased federal payments. I told you that there are a record number of people on Medicare and Medicaid. That's not changing. The older crowd does typically have to choose between medication or food. About 9% no coverage except Medicare. Long-term care insurance, again, that industry has really grown, but it doesn't or hasn't seen nearly the amount of growth that it would need to be anywhere near competitive with social insurance programs. Okay? Now, we talked about this earlier. Everyone is dissatisfied. They don't like the high cost of care. They're not getting adequate care. And something you need to be aware of when you're shopping for healthcare insurance is that there are a lot of hidden factors. The premium may be low, but there may also be a high deductible that you have to pay to access those benefits. Also, your plan may be an HMO plan where you're sent to clinics and places, referred to places that maybe have some junior doctors or people coming right out of medical school that are looking at you and working on you, which is fine. But I said all that to say, to give you a little tip in life, remember to do some research when you're purchasing a healthcare plan. Okay? I'm not going to go into the whole lot about healthcare reform here. 2010 was the last major reform we saw, and everyone knows what happened there. The results that were passed along to the American people in the form of high cost of care and high cost of health insurance. Okay? So it's not very hard to understand. If you mandate everyone to get health care insurance, every able and willing body, American citizen, there are going to be repercussions. And I also like to point out there are 14 exemptions to the individual mandate if you go on healthcare.gov. And they will tell you that you don't have to have healthcare insurance if you're poor or you don't meet a certain standard of living. So what the government does is effectively scare everyone into buying health care. So I want you to think about this when you're having a discussion with people and the topic of healthcare comes up. Is it really that the government and the insurance companies are going against each other? Or maybe it's the fact that a lot of them have something to gain from the healthcare insurance laws. Okay? A lot of campaign contributions were made that you all learned about in POLI 2051, how campaigns work. Somebody has to pay for them. All right? And that's the big donors, namely the banks, namely the insurance companies that the banks are backing. Okay? Now, the healthcare reform, structural flaws in the system, we talked about it already. I'm not going to beat a dead horse. Essentially, they're going to repeal the thing because there are a lot of problems with it. Ideally, yes, it's a fantastic idea. Everyone gets access to care. Everyone deserves that. But everyone already had that. If you needed health care, you had the ability to go access it. But you also have to pay for it too. Nothing is free. Healthcare is a service. It is a professional service. It is not a public good. It is a difference. There is a difference between running your water and having a government run your utilities for you and you pay them for it than having the government run a doctor or a healthcare system. There are a lot of issues with that, okay? And we're not going to get into that. Be aware of that. Institutional care does not provide substantial nursing home benefits, such as Medicare and Medicaid. Most people actually have to do something known as spending down, and that's where they get rid of their assets because they can't afford to go into a nursing home, or excuse me, they make too much or have too many assets, so they have to spend down. And this is a sad fact of life. Even with private healthcare insurance, the insurers will only cover about 45% of the cost. Take a look at the payment sources for LTC, long-term care expenditures. You can see institutional care, Medicaid and Medicare takes up a majority of that, as well as home care. Private insurance, not so much, very low. Out of pocket is the highest for institutional care. Nowadays, this chart, again, this data is a little bit outdated, so bear with me. So there's some things you need to keep in mind. Community-based services, you've all heard me talk about that a lot. That's actually what my research is on. Home and community-based care is what it's known as officially. And what they've done is create programs that enable people to stay at home instead of going to institutionalized care and have the care actually delivered to them. And there are a lot of types of home and community-based services. I won't get into all of them here. This is a brief lecture, but you need to familiarize yourself with those. So long-term care insurance, is it a good bet? Well, obviously that's subjective depending on its individual situation. Some other types of different elderly care services, adult daycare, also respite services, and home health care programs. Okay, so those are your basics. Last point, something to note, changes in funding to control costs. If you recall last year, the Department of Justice cracked down on a lot of home health agencies because they were frauding Medicare and Medicaid, mostly Medicaid, out of Millions and millions of dollars. So take a look at that. Look up that news report. A lot of that happened in Florida and I believe Texas. Some doctors and who signed off on some stuff, and home health agencies who signed off on fraudulent reports were found guilty of fraud to the tune of millions, and I believe it's in the billions worth of dollars, or close to $1 billion worth. So the changes in funding to control costs is something you need to take note of, because you will be responsible for compliance, not the nurses, not the CNAs, not the whatever, your home health agents, your care agents, or anybody else. It will be the administration that has to sign off on the financial reports. Okay, so pay attention right there. Managed care has been the focus of a lot of programs in a sense of medical care settings. Studies do indicate that they somewhat control cost by capitated payments and include a number of different care sources, what's known as an interdisciplinary approach that include, your home health agencies, the hospitals, the doctors, the nurses, all that stuff. And again, it has worked as a method of long-term care planning, but it only works if you catch this in the early parts of someone who is experiencing declining health. Okay, if that makes sense. The whole thing we've talked about a lot within the last couple of years in the industry is the emphasis on prevention. Does prevention really work? Does health promotion really work? Yes, it does. Finally, the U.S. is starting to spend more money and enforcing more regulations that guide people toward leading a healthy life. For example, smoking in restaurants. You've seen a big explosion in the fitness industry especially the last 5 years, I would say. There are more healthy choice items available on menus, such as gluten-free and things of that nature, low fat, sodium-free, that type of thing. And also, water and air quality standards. The EPA has done a great job of enforcing the standards, or attempting to enforce standards that help promote a clean environment, but also coincide with growth in industry. Okay, so health promotion efforts in your community, local community. There's probably a YMCA or some other type of organization that's responsible for community awareness. All right, but the problem is we need more than just a few classes and a few clinics. We need to know that wellness includes a holistic approach that also accounts for the individual's background and the social and the economic context of sickness, the environmental context. Where did the person grow up? Did they have a family that promoted health? In a lot of the cases, and a lot of the patients you'll see, unfortunately, they did not. So the reality is you have to keep those things into account as well, and understand that they do influence illness. Illness is not just medical 100% of the time. It is very much influenced by socioeconomic status and background. Okay, so a few things to ponder and think about in the future of healthcare availability, existence of services. What about no care zones? Well, we talked about insurance companies earlier. A lot of them have actually stopped offering coverages in certain areas of the country because they were losing too much money. Okay, so availability is an issue. Accessibility is another issue. Are people able to get the access to care that they need, or specialized services, for example? Coordination is another big one. Case management. And a lot of times you will be a case manager for a lot of people and a lot of patients. The need for an integrated system, again, is very idealistic. And we've talked about some of the reasons why it's hard to implement federal standards across the board. Okay, so I'm not going to beat that horse again. We've already discussed that. And we've discussed a lot of things. I hope that you all have taken some things away from the lecture and that you've enjoyed it. And that I want you to know that this course, it is an absolute pleasure for me to teach. And I do wish that you all are taking this very seriously and learning as much as you can as you prepare yourself to enter into the throes of being an administrator and the daily grinds that you're going to experience when it comes to patient care and quality patient care and quality of life. I hope that you all have a great day. Thank you for listening. This is Professor Stanley signing off.